Good morning, everyone. Can you hear me okay? Yes. Good morning. Welcome. We're so excited to have you here. This is our annual, typically congressional briefing, but this year we pivoted a little here at March for Moms and are holding a advocacy panel. And I just want to say thank you to the speakers that are joining us this morning, and as well as
our sponsors, to Carl and Maureen for having the space. Thank you so much for all your help and assistance, and to Every Mother Counts as well. This morning we'll go over a little bit about the mission of March for Moms. We'll introduce our panel speakers and also have a guest from the Biden-Harris administration to give us an update of the administration's maternal health goals and policies. So March for Moms, founded in 2017, really began as an organization to raise awareness about maternal mortality and the poor health outcomes that women experience in the United States, particularly related to birth and postpartum period. As I'm sure most people in this room know, we have the highest maternal mortality rate in the world compared to other countries with similar socioeconomic status. So we really began as an organization to try to bring awareness to that, and every year we've had a signature event on the National Mall to really bring this forward to the attention of legislators and people in the industry and try to decrease this rate. Through COVID, we had to pivot and hold our events virtually, but nonetheless, we really kept up with our mission and continue to push this issue forward to the forefront. And I think in the past, especially 5 years, it's really, the tide has been changing to more people being aware of this. This morning, we will have an advocacy panel focusing on the successful strategies in maternal health legislation and advocacy, inclusive of communication, and really focusing on how industry partners, legislators, and people that are doing research on maternal health are using information to push the message forward that we really need some change in how we conduct maternal health care and postpartum care. So we'll have an amazing panel of speakers here coming shortly, and I will first and foremost introduce the Special Assistant to the President for Community Public Health and Disparities, Catherine O'Carr, who will be joining us virtually here momentarily via Zoom. We're really honored to have her. Catherine served on the Biden-Harris transition, and she was also the Senior Advisor at Waxman Strategies, consulting on public health, nutrition, and healthcare issues. During the Obama-Biden administration, she served at the White House as the Associate Director for the Let's Move initiative in the First Lady's office, and as the Senior Advisor in the Office of National AIDS Policy. We really want to welcome her and thank her for her time to provide us an overview of the administration's maternal health strategy, and hopefully she will be joining us here momentarily. I'm not seeing a nod. Great. Yeah. I can go ahead and, since everyone's time is very valuable, go ahead and introduce our moderator, Lori Facina. She's sitting right in front of me here and will be joining us up front very shortly. Lori is the Vice President and Executive Director of Voices for Healthy Kids in the American Heart Association. Through her leadership and direction, Lori has made significant contribution to communities' health through effective public policy. Her expertise includes campaign planning, community mobilization, multi-stakeholder collaboration, and grassroots development to communicate health messages to public officials. She's worked for the American Cancer Society and the Campaign for the Tobacco-Free Kids, M+R Strategic Services, and has been with the American Heart Association for 3 years. She credits the moms who created the Collaborative Parent Leader Action Network in Boston in 2015 with her equity-centered public policy and respecting parents as partners and the initiatives she took forward. Lori's received a bachelor's degree in communication from Emerson College and a master's in public policy and citizen participation from Tufts University. She was named as 10 Outstanding Young Leaders in the year by the Greater Boston Chamber of Commerce for her advocacy on behalf of families and children. And Lori, with Voices for Healthy Kids, increasingly involves advocates for maternal health and children prenatally through age, from age 1 through 3, with the National Collaborative for Infants and Toddlers. I'm going to welcome Lori. Thank you for being here.
Are you ready? Want me to come up?
Anthony, we don't have a word.
You want me to be the warm-up act for the Biden administration?
Sure, that would be great.
There we go.
All right.
If you don't mind doing
No,
it.
not at all.
This is going to be on my resume. I get to be the warm-up act for the Biden administration. And please let me know the minute they're here. Obviously, I will stop. Thank you so much for the invitation to be here. I am new to March for Moms, but I will be involved for a long time. Alicia, Julia, what you did this weekend was awesome. What you're doing for folks around this country is terrific. Voices for Healthy Kids is an initiative within the American Heart Association that many of you will have never heard of, and that's okay. We're very small. We've been around just about 10 years within the American Heart Association, and we work to fund and support campaigns at the state, local, and tribal levels, and try to advance health equity while passing policy. So we're in the much larger infrastructure of the AHA, which has been doing advocacy about 40 years, but we are really small and putting money into communities. So we have funded we've granted about $41 million across the country, mainly to small community-based organizations in communities of color, serving communities of color, and increasingly focuses on maternal and child health, and PM3 is sort of the terminology we use a lot from prenatal through 3. We like to connect mothers and pregnant people with the babies that are born and not have them be separate. So it's been really a learning experience for me as an advocate to come into this world that is gigantic, sometimes seeming siloed, very, very vibrant and exciting. When I think about advocacy, and you've heard from my way too long bio, I've been doing advocacy work for 20 plus years. What I'm always interested in is like, why does somebody become an advocate? Like this room of people here, like what motivated all of you to do this? What motivated anybody who's doing this to do this? And I know from my own background, but from folks I've worked with through the years, I always think the best descriptor is get them mad, get them motivated, get them moving. If you have a feeling about what you're doing, if you're connected to the emotion of something, you're so much more likely to want to be an advocate. And we're going to have a great opportunity here today to hear from 6 panelists, most of whom got mad at one point and had a personal experience that motivated them to get moving and have continued their work in ways that not just have improved and hopefully improved their lives and their families' lives, but are having ripple effects for people across the country. I've gotten to be on the phone with all 6 of them. I've been completely touched by what they brought in. But I want to just say, like, for anybody who's watching out there in the real world, or staffers who are working for decision makers in Congress or state legislatures, everybody who comes before you as an advocate is doing so with a little bit of trepidation sometimes, because it usually is personal to us when we come to you. So know that if you're nervous meeting with us, we're just as nervous meeting with you, and that heart and soul that we bring to this work is usually based on somebody back home, or somebody in our family, or somebody in our community that didn't have the ability to have the voice, or somebody who wasn't sticking up for us in the first place to make some change. So when I think about advocacy, I think about the emotional part of it. It's very emotional to me. And I know when you talk to like regular people who don't do this work, they think we're all these crazy rabble-rousers who are super polarized and only see things in political terms. I don't buy it. I think we're human beings who care about children, babies, and families and communities. And I don't care what side of the political aisle you are on, or what part of the country you're in. The people that become the best advocates are the folks who have the most emotional connection to it. And as I've gotten to know March for Moms and seen what you put out there in the world, it has been super impressive to see that the heart is always at the soul of what you're doing. I'm excited to continue working with all of you. For folks who want more information about the organization, please check out their website. There's lots of information about how to get involved. There's lots of terrific information about child and maternal health. There's lots for us to build on together. I am very excited about the panel today. I am looking to see if we have our folks from the Biden-Harris administration, and if not, I am going to, should we ask, is it okay to ask the panelists to come up?
That would be great.
All right, so I'm gonna ask my 6 fabulous panelists to join me here. And I am, not to pick favorites, but I do have one. I have many favorite organizations, but I've been a huge fan of Moms Rising for years, long before, right? Keep it up for Moms Rising, seriously. So they do amazing, amazing work. Tina Sherman is going to be our first speaker. She is with Moms Rising as the senior campaign director. her mom will live stream today. I think that's the best thing for anything that's a March for Moms. And Tina, I'm going to ask you to pass it to Brian when you're done, and we'll just go down and everyone can make introductions. But we will be interrupted at some point by the Harris administration. But thank you, Tina. Take it away.
Thank you. Good morning. It's so good to be here. Thank you so much again. My name is Tina Sherman. I'm Senior Campaign Director at Moms Rising for Maternal Justice. Moms Rising is a national, on-the-ground and online organization working on family-friendly policies so that we can build a better nation for parents and families to be able to thrive. My specific focus is on maternal and infant health, and I advocate for family-friendly policies like paid family and medical leave, breastfeeding accommodations in the workplace, pregnant workers accommodations, improving access to healthcare, and helping to eliminate disparities. And our real focus is to bring the voices of real families to decision makers, both at the at the local, state, and federal levels. So what we often do is talk with our members, encourage them to share their personal experiences, because walking the halls of Congress are many people who don't look like us here in the room, and we need to be able to express and bring the voices of real families to the folks who are making the decisions. So that's really one of our key focuses at Moms Rising. I'm going to pass the mic to Brian.
Thank you. My name is Brian Gravel. I have been in the maternal health space since I lost my wife in 2018, and even a little prior to that. My wife, Leanne, died from complications of preeclampsia in the fall of 2018 after giving birth to our two beautiful twin boys, Charlie and Enzo. Up to the point after she gave birth and had eclectic seizures, flash pulmonary edema, was treated by inexperienced people in that space for a good deal of the time. She took up the banner and she decided to March for Moms, which is the organization that she trusted most to get her message out. After she passed, carried on her legacy, we started the Lean Escabel Center for Maternal Health in Rochester, which focuses on hypertension-related pregnancy disorders, primarily preeclampsia. We have a cuff kit project. We work in conjunction with the Preeclampsia Foundation, delivering cuff kits to historically ignored communities in the Rochester area. Rochester happens to be one of the poorest cities in the nation. We have some of the highest poverty rates in the nation, some of the worst maternal health outcomes in the state of New York. It's a space that is gaining a lot of attention, and there's a lot of people working in that space, but there's not a whole lot of synergy at this time. So my organization worked with a couple other brilliant individuals to really sort of focus that attention there and make sure that we're providing resources to the community that are absolutely required, and bring attention and awareness to the negative outcomes that we're seeing in our city, especially among our, again, historically ignored communities. Outside of that, really hope that we can bring voices to the people who are impacted by this, and we can bring better storytelling, get people in front of their representatives, bring more grassroots direction towards our advocacy, because that seems to be incredibly effective. I'm sure we'll talk more about that here soon.
Hi, I'm Taylor Penn. I'm the Policy Director for the Maternal Mental Health Leadership Alliance. I actually just started this position about 2 weeks ago, so very excited to be here on behalf of MHLA. Thank you to March for Moms for hosting this wonderful event. Oh, I'm going to pause because we have a special guest here.
Yes.
So for me, yeah, hi. I didn't realize you were waiting for me. I was just listening, and so I didn't want to. But thank you for having me virtually. So nice to be with you all. I'm Kat Okar, Special Assistant to the President for Public Health and Disparities here at the White House. So appreciating you letting me crash, albeit virtually, but just have such respect for you all and for the organization and for the issues that you represent. So I just wanted to talk a little bit about kind of where we are as an administration in terms of maternal health, and obviously this is a huge priority for the president and the vice president. As I'm sure many of you know, she was a huge maternal health champion while she was a senator and continues to really drive that here at the White House. I think, to be frank, and I think this, you all are no stranger to this topic, but I think we very much recognize that we are facing a maternal health crisis in this country, and the fact that our country's maternal mortality rate is higher than any developed nation and more than double the rate of some of our peer countries, and that so many of the pregnancy-related deaths are preventable, it is unacceptable. And so I think, the challenge in front of us extends well comprehensive coverage. That's huge. That is huge. 4 million people. We also feel strongly that Congress should require all states to provide continuous Medicaid coverage for 12 months postpartum. As I know you all know very well, currently states are only required to provide pregnancy-related Medicaid coverage for 60 days postpartum. So somebody delivers a child and only has 2 months of coverage after that. Can you imagine, like, you're stressing already about a new baby and human in your world, and then you only have 2 months of health insurance coverage, and then the stress continues. And so that to me is really huge. And in the past week, we've seen a number of states, California, Florida, Kentucky, Oregon, expand Medicaid coverage to 12 months postpartum. And several states have already done this, and this is not a small thing. And it is actually really impactful when you think about Medicaid covering 42% of all births in the country, 42%. And so, and the fact that we know that many of the pregnancy-related deaths, again, something that I know you all know very well, occur between 1 week and 1 year after childbirth. And so we know how critical the postpartum period is for recovering. We're also trying to do more in terms of the hospital front. And so the Centers for Medicare and Medicaid have proposed a new designation that will be deemed something along the lines of like birthing-friendly hospitals to help families know what hospitals are focused and taking steps on ensuring that their maternity care is high quality. So that is in the works. And then broadly, back in December, the Vice President announced a call to action to both the public and the private sectors to help improve maternal health outcomes for parents and infants in this country. We're also making a huge push to Congress to make significant investments that work to improve maternal health. In the President's FY 2023 budget, we included $470 million to address the maternal health crisis in this country, and that money would do a ton of things, and that means everything from expanding initiatives in rural communities, implementing implicit bias training for healthcare providers, creating pregnancy medical home demonstrations, supporting the perinatal health workforce like midwives and doulas, which I know many of you are, strengthening data collection, which is not like super glamorous, but it's so impactful, and of course addressing behavioral health disorders. This also obviously includes extending and increasing funding for the maternal infant and early childhood home visiting program, which, as I suspect many of you know, serves families at risk for poor maternal and infant health outcomes each year. And lastly, I just want to say that our work is really underpinned by a continual focus on advancing equity. We recognize how important this is. We recognize that health does not exist in a vacuum, and that maternal health outcomes are markedly worse when pregnant and postpartum women are housing insecure, when they're hungry or live in areas with toxic environments and chemicals, when they don't know where they're going to get their next paycheck. And so we're really trying to think through how we get to a country where every person can have a safe, dignified pregnancy and birth, and where there's equitable access across the board to healthcare before, during, and after pregnancy. And so we're trying to take as many steps as we can. We're trying to build on a lot of the work that we have already done and continue to do. This builds on a lot of kind of some of the executive orders that the president put out on day one of his administration. It also, this is something that we constantly talk about in the administration, and I don't know if it's like a very kind of bureaucratic word. We talk about a whole of government approach, which sounds like so boring, I know, but it's actually true, and it's actually super cool because it means that like we're not just having one, gosh, I'm like such a policy nerd, but it actually means that we're not just having one Department of Health and Human Services focus on it. We're just not just having U.S. Department of Agriculture focus on it. We're really thinking about this across the board. So what can the Department of Defense do for our military families and military women? What can the Department of Veterans Affairs do for veterans who are pregnant or postpartum? And so we're really trying to think about this across the board. How do we work with our housing and urban development colleagues to make sure that they have the housing they need, whether during pregnancy or postpartum? And so the last thing I wanted to say was we so value the work that you all are doing. I know this is an issue that continues to persist over and over again. It's heart-wrenching and heartbreaking and unacceptable. And so to the extent that you all need anything or we can do anything, we'd love to continue the conversation. And just so appreciate the opportunity to speak with you all, and I can see myself on the screen, which is like so painful. But just really appreciate the time and the work that you all are doing, and please don't hesitate to reach out if I can do anything or you'd like to talk again. I will leave it to you to have the rest of your day, but again, appreciate all the work that you're doing and look forward to talking more. Have a good one.
Thank you. Thank you, Pat.
Okay, so back again. So I became a mother for the first time in August of 2020. I had friends who had children, so I'd heard of postpartum depression. I thought, okay, I need to mentally prepare for this. Told my spouse, I'll probably have postpartum depression. What I wasn't expecting was the prenatal anxiety that I experienced starting around 8 weeks. I started having anxiety attacks about 2 or 3 a week. They were really debilitating. They were affecting me being able to get through my work day and to be able to just really live my life. After a couple of weeks of experiencing this, I thought something is wrong. I talked to my midwife. She actually discouraged the use of medication because she said it would hurt my unborn child. And then I talked to my primary care doctor, and she was incredibly supportive and said, you know, there's a lot of medicines you can take that will help you. They are not going to hurt your child. So I got on medication. I thought, I'm good. I'm prepared. I'll just go up on my dosage if I need to if I experience postpartum depression. So, you know, I had my daughter in August. I had baby blues like most moms do, most birthing people do. And then about 6 months after my daughter was born, I started having intrusive suicidal thoughts. So, you know, I had a therapist. I was on medication. You know, I have a supportive spouse. And, you know, I'm going on a walk with my baby thinking, you know, they'd probably be better off without me. I should probably just kill myself. And I remember one day coming home from a walk telling my husband that I don't want to leave you, but I'm having suicidal thoughts and I need help. So I was able to talk to my therapist, to talk to my friends and family, and to get the help that I needed. And one of the things I really needed was time off, and I was able to file for short-term disability and to get the time that I needed to heal my brain. And so I'm still here today and able to talk with all of you. And what I experienced is incredibly common. 1 in 5 women and childbearing people experience maternal mental health conditions. So in addition to anxiety and depression, like I mentioned, this can also include PTSD, OCD, bipolar disorder, which can include psychosis, and also substance use disorders. So suicide and overdose combined is the #1 cause of maternal mortality in the postpartum period, and this is 100% preventable. I also want to point out that people of color and low income, folks who are living in low income situations are more likely to experience maternal mental health conditions, less likely to receive the care they need, and right now, 75% of people who need treatment are not getting that care. That's completely unacceptable. The Maternal Mental Health Leadership Alliance, or MMHLA, we are a nonprofit, nonpartisan organization started in 2019. We advocate at the federal level for universal education, screening, prevention, and treatment. And we want to see a world and a United States that is really coming behind women and childbearing people, supporting them. And first of all, we would like to prevent maternal mental health conditions, but if that is happening, we want to make sure that people are getting the support that they need exactly when they need it.
So hi everyone, Brianna Lipscomb. I'm the Senior Advisor of Maternal Health and Rights for the Center for Reproductive Rights. I'm based in Atlanta, Georgia, but I work really closely on both state and federal policy. The center is a global legal advocacy organization working to advance reproductive rights as human rights and to secure those rights in the law. What's been really interesting about our work is, whereas we've worked in the maternal health space globally for quite some time, our portfolio in the US really didn't focus on maternal health until around 2014, 2015, when we were working with partners to unveil the maternal health crisis that we're experiencing in the US. As a person with a public health background, it's been really a kind of an interesting shift in my approach to the maternal health work. So I started out working in state government and other nonprofit organizations that were really rooted in, how can we make sure moms are healthiest, before they get pregnant, which I think is really important. But when I came over to the center about 5 years ago, thinking about how we can apply a human rights framework to the policy was really a shift, but a needed shift, because what we know now is that you can have a woman that is perfectly healthy and still she can die from pregnancy. I remember reading an article a couple of years ago that was saying that a Black woman with the exact same risk factors during pregnancy as a white woman is still more likely to die. And Lori, I know earlier you mentioned, you get mad and you get motivated, and that's what propels you forward, and that has really fueled my passion in this area, because to me, what I thought about was my sister, I thought about my friends, I thought about just other Black women, Indigenous women that I see on the street every day, and so that is really motivating me. I think particularly because the center takes a human rights framework approach to this work, has been a challenge, right? So like when we work in our global spaces and we think about, a case that we brought in Kenya where a woman was beaten and detained for not being able to pay her hospital bills. We saw an Afro-Brazilian woman die in the hallway of a hospital because she was denied care. And I think sometimes when we come back to the US, it's like, well, we may not see that level of human rights violations, and yet human rights violations are still occurring here within our own borders. And so I think part of what the center has been working to do is to really explain what human rights violations look like in the US. It is mistreatment, it's neglect, it's not listening to birthing people when they're saying that something is wrong. It's not giving folks access to equitable, respectful care. And then how do we take those stories and translate it into policy? So we do use a human rights framework. We employ these core human rights principles around government accountability to the right to health, which is more than just access to health, but making sure that health and health care is accessible, available, of good quality. And then it's also making sure that we're centering the voices and the lived experiences of the communities most impacted. So a lot of the work we do is working directly with community-based organizations that are led by Black women and by Indigenous women, and giving them the tools and resources they need in order to engage in the advocacy process. I'll just really quickly say, when I think about our policy priorities for our maternal health and rights initiative, it's centered on many of the things that Kat was just talking about earlier, improving data quality, because we know that what the data shows is what drives policy. So, sometimes our policymakers choose to root decisions in evidence when they want to, and so we want to make sure that that evidence is really reflecting the actual circumstances. The second is expanding access to care. And that could be a variety of things, from expanding access to mental health care, to extending Medicaid coverage, to making sure that folks have affordable access to doulas and midwives. And then finally, it's addressing racism both within and beyond the healthcare system. So everything we do is centered in those three priorities. So.
Awesome, thank you. That's really interesting. Is that something? Okay. Hi everybody, my name is Evan Hoffman. I lead state and local government relations for Philips, a technology company. So I'm here representing the technology point of view in this whole space, which is very important. So I'm just going to start by show of hands. When you think of Philips, how many people think of light bulbs? Okay. What about TVs? Philips TVs? A few. What about crab cakes? Philips crab cakes, local Baltimore people. How about Sonicare toothbrushes? Yeah. All right, so Philips, believe it or not, we're 100% healthcare tech now. So we sold all of those other businesses. We no longer do light bulbs, we no longer do TVs. We actually never owned crab cakes, but that would have been fun. We are 100% healthcare tech, and we've been making this transition over the last few decades. So Philips, as a company, our mission is to improve the lives of 2.5 billion people every year by 2030, including 400 million people in underserved communities. We do this by developing healthcare technology solutions almost in almost every single healthcare setting, from the home to the ambulance, to the doctor's office, to the hospital. We make all these different types of products like ventilators, AEDs, cardiology tools, imaging machines, patient monitoring equipment, telehealth tools, just to name a few. So Philips has a deep, deep legacy in maternal and infant health. We're the world's largest maternal health technology company. So we've been involved in this space for a long time, and it's our passion to work with lawmakers to advance better maternal health outcomes. Philips is the world's largest ultrasound technology company, the world's largest obstetrics monitoring company in the hospital. We manage the world's most downloaded pregnancy app globally. So how many people here have heard of Pregnancy Plus or have used it before, perhaps? 43% of all first-time moms in North America use Pregnancy Plus. In Europe, in some countries like Germany and Switzerland, it's as high as 90% of first-time moms use Pregnancy Plus. We also own Avent, which is a very popular baby product company that I'm sure everyone here is familiar with. So it's a very important space to Philips, as you can see. In terms of policy, in terms of what we're thinking about every day as we develop new innovations, we're trying to tackle many of the same challenges here that everyone's talked about. How can we leverage technology to increase access to care in the home? How can we bring better maternal health care into the home, regardless of where you live, whether it's inner city, whether it's in rural America? And we're trying to tackle very important challenges. You heard the White House staffer talk about issues surrounding morbidity. So it's not just maternal mortality, but some of the issues that might drive some of those outcomes, like the fact that almost 10% of all births in this country are delivered preterm, or the fact that we have over 30% of births in this country are delivered through C-sections, which is double the World Health Organization recommended average. So all of these challenges increase costs, right? So they put more pressure on Medicaid, they put more pressure on insurance, which we all pay through higher premiums. $32 billion a year, the March of Dime estimates that preterm births alone cost this country. So these are some of the challenges we're trying to tackle through technology. We're developing some really cool things to hopefully improve some of these numbers. We can do tele-ultrasound now. Has anyone ever seen this before? Right, so imagine taking a transducer and plugging it into a smart device. You can now bring tele-ultrasound into the home. So imagine working with doulas, midwives, training them on how to deliver tele-ultrasound in the home. Just imagine what we can do. A non-stress test, that can also be done in the home. So for the 25% of moms who are high risk in their third trimester, they might be required to go to see their doctor twice a week for a non-stress test. How do you make those appointments if you're balancing a day job, if you have to find childcare, if you live in one of the half of the counties in this country that don't have a licensed OBGYN? How do you do that? Like, so many moms face this impossible decision of taking time off work, of trying to figure all that out, versus adhering to their care plan that's recommended by their doctor, and we wonder why we have such high preterm birth rates, right? So we can bring non-stress tests into the home through telehealth now. So instead of traveling to the doctor twice a week, you can now do a non-stress test in your home, 20 minutes, while you're watching Netflix, right? So these are some of the things we're trying to solve. The other big thing we work on in relation to what Brian was talking about is remote patient monitoring, which is very important for high-risk moms who have high blood pressure or who have gestational diabetes, for example. So my job is to work with state lawmakers across the country and identify legislative opportunities where we can drive change. So some of the things that we talked about here, like expanding coverage for Medicaid postpartum to 12 months, ensuring that your state's telehealth laws facilitate, enable, empower doctors to offer this type of care. So these are the types of things that I'm working on every single day. We've got lots of really good examples that I can share in Q&A about some of the work we're doing with specific states. But that's why I'm really excited to be here with you all. So thank you.
Hi, I'm Gene DeClerc. I don't represent a group. I'm a researcher at the BU School of Public Health, longtime professor there. Ginger asked me to be on the panel because she wanted to get some age balance to the panel. And so I thought that would be an appropriate role for me. Mostly of late, I've been doing research since before most of the people on the panel were born, okay? So, and I've always tried to look with colleagues in collaborations on different kinds of questions. And so I'm part of a group that's been doing a series of surveys called Listening to Mothers that dates back to 2002. With other colleagues, we've tried to take existing data and look at it in a different way. To tie it into what we've been talking about, we just published a paper on the rising prematurity rate. And what we found with it, and this was my longtime colleague, Mary McDormand, who just tragically passed away recently, literally the week before she died, she was writing me notes on getting this paper out. That's how important it was to her. And what we found was, overall, there's an increasing prematurity rate, right? There was a rising rate for a number of years, then it dropped after 2007. From 2007 to 2014, the prematurity rate actually declined. And since 2014, it's been going up again. And we had done an earlier paper on that, we revisited it. And what we found was, as the overall prematurity rate's going up, the prematurity rate for spontaneous vaginal births was going down through that whole period of time. All of the increase in the prematurity rate was associated with inductions and cesareans. When we did the research 10 years ago, and we were looking at that earlier period of a rise, what we found was it was mostly associated with cesareans. In the more recent paper, what we found was it's more strongly associated with inductions. There's been a massive increase in induction in the United States. And so a lot of what we do is try to ask questions about the nature of care and different ways we can approach care. So I just want to make a couple of points around that, on research. The role that research can play in policy is mixed, because as was noted, policymakers often don't listen to research. And one of the problems we have in our research is we don't frame it appropriately for policymakers. We think that we should walk into a policymaker and say, my God, look at this, it's an adjusted odds ratio of 2.3. Why won't you pass a new policy, right? And that doesn't make any sense to them. And that's on us to try to change that, right? So how do we link this up? And I'll note a couple of cases where I think that's been successful. One is CDC for years was putting out a pregnancy-related mortality rate. Nobody paid attention to that. It was only when people started calling it a maternal mortality rate that the crisis in maternal mortality became known. The data on that rising rate had been there. They've been publishing it every year for decades, and people weren't paying attention to it. So the power of symbols, the power of framing is critically important in the advocacy process. Then they finally, after cajoling, harassing from a bunch of people, started putting out death rates by the timing of birth, by the timing of the death, because they would just put an overall rate. And the overall pregnancy-related mortality rate is based on deaths from the beginning of pregnancy to a year afterwards. And we said, please, will you put it out by time period? And when they put it out by time period, it changed the whole discussion. We wouldn't be having the extending Medicaid discussion if they hadn't done that. because it was when they put that out, it became clear that there were significant numbers of deaths that were occurring in the postpartum period. And that leads to the next point, which is, if you look at the data on the timing of deaths and the place of deaths, deaths in hospitals are going down. Maternal deaths in hospitals are going down. Maternal deaths in communities are going up. And that's not home births. That's simply the fact that it's during pregnancy and the postpartum period. If you look at the work that's been done over the last decade, there's been tremendous work done at the hospital level. They're improving care enormously, much to their credit. There's a long way to go, but they've made great strides. What hasn't been improving nearly as quickly is community-based supports, because we're so used to putting all our resources into hospitals. And there's a nice institution and an institution that wants to make change, and so if you put money into them, and policymakers think that way, because they're talking to other powerful people, not community people. And so they're comfortable with that. But the fact of the matter is, a third of the deaths occur at the time of birth or within a week after birth. And about a third occur during pregnancy, and about a third occur between a week and a year after. We need to do work at the community level to have much impact. That's a much harder sell, because it's not who policymakers are comfortable to working with, right? Two other things I'll just note. One is, in looking at this, and it ties into some of the earlier points, deaths to women of reproductive age are going up faster than the maternal mortality rate. That's not maternal deaths, we're talking all deaths. If you look at the deaths of women between 15 and 44, that rate has gone up faster than the maternal mortality rate has gone up. And so maternal mortality, we do tip of the iceberg, canary in the coal mine, all of those metaphors. But basically, it's simply capturing a small piece of what's a much larger problem in terms of reproductive health in the United States. And we need to work on those issues as well. It's not a separate matter. I'm on the Massachusetts Maternal Mortality Review Committee, and we take all of the cases of maternal deaths in an MMRC, or MMRC, depending on those who aren't from Massachusetts. And we look at those cases and we decide which ones are pregnancy related. And I'm not a clinician. I don't look at many of the clinical cases. I look at what you might consider social cases. And it's mostly substance use. And what you find is that we need to reconsider how we focus on pregnancy. The best way to think of it is, pregnancy is a time when we can maybe make an impact when we couldn't otherwise. Because what you see, particularly in the substance use cases, is women who have had very difficult lives. You look back in continual interactions with the law, difficulties here and there. But during their pregnancy, they make extraordinary strides to try to protect the health of the baby. And we get them into services, and what happens is they have their baby, and DCF, or however it's called in your particular state, the community and family groups, will come in and take the baby away, because her life is still pretty erratic. And then she collapses, and she's gone, and she starts using again and overdoses, and that's the only reason we would see them, right, in the review committee. And the irony of that is, oftentimes those aren't considered pregnancy-related deaths, right, because the difficulty far preceded the pregnancy. So instead of thinking of it as, are we going to look at pregnancy-related deaths, we have to look at it as pregnancy as an opportunity to get people into care that wouldn't have gotten care in any other way. But the thing is, we have to keep them in care. And the reason we don't do that is we don't actually value women's health. We only value babies' health. The whole structure of the system is around babies' health. And I want babies to be healthy, but the way we've structured this, the 60-day cutoff on Medicaid, is a function of the fact that we say, you've done your job, you've had your baby, we don't have to worry about your health anymore. So until we value women's health for itself, we're not going to have the impact that we hope. I told Laura I was going to go 45 minutes. I'm going to cut it to 40. I just note one other thing. Research that will be coming out that isn't published yet, but that's been accepted in a journal, that'll be coming out at the end of the month. We looked at COVID-related maternal deaths. And I can't give you the specific findings, but I'll tell you the general finding, which is, no surprise, COVID exacerbated disparities to a profound degree, and particularly among Hispanic mothers, which was interesting. Hispanic mothers historically have had lower maternal mortality rates than the non-Hispanic white mothers. And at least in the last 9 months of 2020, that was the first time that's flipped. And higher rates of COVID seem to be, we can't prove it. It was just a relationship, not a causal one necessarily, but suggested that there are things that need to be done. So research can have an impact. It's up to us to do research that actually matters and try to translate that into a way policymakers can have an impact.
Before we get to the discussion, can we just give the panelists a round of applause? So anybody who's been listening to this aren't your soul, right? Of course, decision makers at the state and local and tribal congressional levels are going to agree with everything you say. I mean, it made perfect sense. There's perfect logic, and yet that's not what happens in real life. And I would love to. By the way, they're all looking at me and saying, this was actually not in the script, so. If you can see their eyes open up, it's because you went so far beyond. I'd love to just take the conversation into a different place. One of the kind of things I always like to keep in my mind, and I think we talked about it a little bit on the prep, is being an advocate is not this, right? This is perfect logic. This is your perfect, like you were making your case. But the truth is, you sort of made the case for what you want and why you want it. But how we do this is to understanding who has the power to give it to us, and how we talk to those people that have the power to give us what we want is as important, sometimes more important than this. And sometimes as advocates, and I've made this mistake way too many times in my career, we're so hell-bent on getting people to understand everything we know about the issue instead of spending time on understanding who they are, what makes them tick, how am I going to make this work for them. And today, you can like Google people and find out just about everything. When I started, we had to like talk to lobbyists to understand the backstory of everybody. Now you can find out so much about decision makers. 15 minutes of research. If, like, for us not to do that, it's shame on us for not doing that. But I think that there's so much work that goes into this, and I think sometimes when we're trying to get grassroots folks in particular engaged in advocacy, we don't always necessarily prepare them with that piece of it. And I would love to just hear from maybe each of you actually, because you've had to tailor your words and work with advocates around identifying first that that decision maker self-interest. There's 6 people here. If I was trying to convince all of you to do something, I would want to know a little bit about each of you and talk to you a little bit differently. You're not all going to be motivated by the same thing. That's true in a city council, in the state legislature, and certainly true in Congress. I would love, if it's okay, Brian, to start with you, because when we had our pre-conversation, you had some really insightful things to say about how you got to know these decision makers, relationships, and what really made a difference for you. The story you had to tell was incredibly compelling, but you were very clear that alone wasn't going to do it. So could you kick us off and sort of share some experience? And I'd love to hear from others about like knowing your audience and being okay targeting your message to that audience.
Yeah, I think that, like, just to start off with, is that I have no formal training in this. I don't have any formal training in talking to legislative aides or legislators. I'm not formally trained to deliver talks or be an expert on a panel in any way, shape, or form. I have a personal experience, and I'm not afraid of putting in a lot of hard work. I got to know my state senator in New York State, Senator Jeremy Cooney, great guy. My wife was working with him before she passed away on his campaign in the public health space. He came to the funeral and he came up to me and he's like, we're going to win this election and we're going to get a bill passed. We're going to do legislation on this. And I worked for him for the next 3 years. I worked for a state senator, didn't get elected in 2018, unfortunately. Ended up getting elected in 2020. For 3 years of my life, I breathed local politics to make that happen. Gets elected in 2020, March 1st, he calls me up, says, we got a bill. We got a draft. It's gonna amend the public health law. It's going to put state dollars that are already allocated, in this particular sector, and it's gonna make them available for free benefits. We're gonna call it Lean's Law. In June of that year, it was passed. It was the first constituent service bill in the maternal health space in New York to pass in 10 years. And that was, so again, signed by the governor in June of 2020. Since then, session just ended on Saturday on my way down, Saturday morning, the New York State Assembly adjourned. Since 2020, since that bill passed, we've had 12 more bills, 12 more maternal health bills many of them involved in the mental health space, have passed in the last 2 years. It's okay to drive a wedge. It's okay to take a small bite. It's okay to break off a piece that's manageable, get it done, because it opens the door for other people to come in and do those things. And I think that, like, if there's one thing that I can ask people to take away with, it's don't get sucked into the big picture fight. Don't get sucked into the federal argument that goes nowhere, and push and pull. There is a very real ability to connect with your local policymakers. They crave a real human connection, believe it or not. I know that they can seem unreachable, or they can seem aloof to our problems sometimes, but they really do crave a human connection, and that's what makes this stuff happen. And if I could ask for something from anybody here who is in the public or private sector who wants to throw money and assistance at this, it's take people like me and train them to tell stories, train them to how to talk to these people. Let's get these messages together. Let's document them. Let's get them. If I could, I was telling somebody yesterday. If I could have a stack of papers this tall of everybody that I know in the last 5 years who have died or had a close call in a hospital, and I could take that stack of papers of stories, I could plop it down on somebody's desk and sit there and make them read it, I would. And that's a real goal that I think that we could actually accomplish and would actually make a difference.
Thank you. I'm going to ask you guys prepare. Moms Rising does such a great job of preparing advocates for the first time for these conversations. What's the methodology? How do you do it?
Well, part of what we try to do is when individuals and families like Brian's comes to us to share their story, we want to first of all honor that story, honor their experience, and our goal is to really make it as simple as possible for individuals and for families, because they're sharing such a traumatic experience that they've gone through that we really don't want to re-traumatize. We want to minimize that, and then we prepare them for talking with their lawmaker, whether it's fortunately we at Moms Rising have the opportunity to work with at the local, state, and federal level, and so we really try to prepare for what questions you might receive. If you're going to talk with the media, we try to sit down and figure out what are those components that you're most comfortable sharing, which ones you might want to hold back. And everyone, each individual needs, wants different things, right? Like how they feel like conveying their story. Some people don't even want to speak with the media, but they might write their story. They might write an op-ed or a letter to share their story. They might write a letter to their senator. We can help them sort of craft that, or their lawmaker. We can help them craft that. But really sort of tailoring it to each individual person who wants to share their story. And then we as the advocates come in to provide that additional context. We don't want you to have to do that ask. We really just want to make it simple and have you share your story, because the reality is that lawmaker, Ryan, such key things that you said, that they crave that connection. They don't know. They don't know what you have been through, what your sister and your aunt have been through. They need to hear that information so that they can make those better policy decisions. And closer you are, whether you're at the state whether you're at the city and county level, or you're at the state level, those connections are that much more, and you can make that much more of an immediate impact. But know that those folks at the local and state levels, some of them may continue on to pursue other offices. And so know that through your story and your experience, you're building champions who may then go on and run for a different office. And so knowing that those connections, you're building that relationship now, which are so, so critical, and you're educating now on those issues. But Moms Rising really likes to try to make it as easy as possible in helping our members prepare to share their stories, because it is a traumatic experience to reshare, and we want to make that as easy as possible.
Thank you. I'm wondering how many folks staff over the years, turn the tables on them and give them space to share what their own experiences might be with maternal health issues, maternal mental health, any of these issues, because it would seem that probably many of those families have been affected, and I'm just curious if that's anything that you bring into the conversations you have with decision makers and how it's gone. Gene?
I had the privilege 2 years ago to speak with Charles Johnson, who many of you know, and Ebony Marcel. The three of us spoke to the Black Maternal Health Caucus. And what was striking was, I mean, we all do our thing, and we didn't need to do it because the congresswomen themselves, black and white, just took over. And they all had their own stories. They all had stories of either their own mistreatment or the mistreatment of one of their children in childbirth. And so one of the things we do have going for us is that personal level of experience that what we don't have going for us is a lot of power and money, and that does count in these kinds of lobbying efforts. But what we do have is that connection that they all felt this. They all knew once we even began to tell the story what the kinds of things we were talking about meant, and they just took the meeting over, which is great.
Yep, 3 of the 5 co-sponsors on Lynn's Law all experienced some type of prenatal health issues along with pregnancy. 2 of them were preeclampsia specifically. So, and they were more than happy to share their stories. It became very personal for them, which was really wonderful for getting things done. And again, it's driven this kind of push in the New York State legislature over the last 2 years. It's been great.
Yeah, and I'll add to that. I'm grateful for several opportunities I've had to share space where not only have I had members sharing their stories, but then all of the lawmakers and decision makers have then turned around and shared their stories, and again creating just that great equalizer of we are all in this together, we're all experiencing this. But then I've had opportunities in which a member sharing their story and then a lawmaker sharing their story. The lawmaker didn't know that this was, gosh, beyond going back to what you said, a human rights violation. They didn't realize the scope and the extent of something they had experienced was not normal. And so we were able to sort of educate them on that. And of course, what a greater advocate that we have, and then and an ability to push on the legislation. So I appreciate your the Center for Reproductive Rights framing around human rights, because that really, in this particular instance, really sort of drove home the importance of moving on these policies.
And just building up that, I want to really highlight something Tina said earlier about how we can engage with a lawmaker at this point in time, but thinking about what their other aspirations might be. I think Vicky Harris is the greatest example we have of someone that we cultivated when she was a junior senator on the maternal health issue, and now as a member of the administration, and really the pressure that she has put on agencies across federal government to do some sort of whole government approach to maternal health has really been phenomenal. But it started with those early seeds of let's figure out how we can address this issue, and her, of course, being a major champion of the original version of the mom list was really key to that conversation. But I think that we can't take for granted how lawmakers receive the information that we're sharing, and what could eventually, it might take time, but what could eventually become something really, really impactful.
I love that. I mean, we're in this for the long haul. This
Right.
isn't, I know there was a lot of hope, maybe there still is, about what might happen in Congress this year. Let's pretend there is.
There's hope.
Maybe not a lot of hope. There's some. But there's we hold this thing up here, there's this holy grail that's going to solve all the problems. But I think your points about relationships starting even at the local level, even with city councilors, state rep, whether they move up or ascend to higher positions of power or not, almost is irrelevant, because I think we also want to be engaging those parents and family members and citizens who care about this issue every day, and building those relationships, doing that homework. There's easy ways to get people involved right off the bat, because it's not just when there's a vote. I think that sometimes advocacy organizations can make that mistake of only activating people when there's a vote that's needed or something, and then the list goes cold. There's so much to be, this is a 24/7 relationship building machine if we do it correctly, and it's super powerful. I also think that there's there is something to asking folks their own personal experience and listen, and just listen and write it down. Let your lobbyists know, not in a creepy way, but just when there are people that have personal experiences, that becomes part of your internal power base, and we shouldn't forget about that. That's incredibly, incredibly powerful. Leah, I wanted to ask you, and I know you're in a new job now, but you've been in this field for a while, about tools to prepare advocates. Like, what do you give folks if they're going in to meet with a lawmaker for the first time? Like, what's the best way to prepare people for those kind of things? We talked a little bit about the emotional pieces of it, but how do you give, what's the stuff they should be going in and meeting with staff and lawmakers to be successful in those interactions?
Great question. I mean, as most people in policy know, there's, the one pager, right? The front and back that you're gonna leave in the office. MMHLA, like any policy org, has a lot of those on our website. You just wanna make sure that they are short, that's just the front and back, and they're engaging, right? That interesting graphics, you're not just gonna write something on Microsoft Word and be like, here you go, no one's gonna read that. They have so many people who are coming into their office, and you also wanna make sure that there's statistics that are, and you're gonna wanna think about the language, like someone said earlier, you're gonna think about the language, you wanna think about, how are you maybe gonna catch their attention, like what are people talking about right now on the Hill, how can you link in your issue, and then also put it in an economic point, because even, if you're really wanting to sell the moral story that, that number, how much it's gonna save, how much it's costing, is always really important. And then if you're able to put in someone's story, even if it's a short little snippet, that is also really powerful. MMHLA has a yearly advocacy day that we host with our sister organizations, 2020 Mom and Shades of Blue. And this year it was virtual. And we had over 100 advocates meet with 115 different offices to be able to share their stories, and we help prepare people by having a toolkit that really has, a script of these are things you can say, this is how you can prepare, sort of an advocacy toolkit, but also thinking about what some other people have talked about. You're talking about building a relationship with offices, as a national policy org, we do want to build that relationship, and we also want to say, when we ask them for something, also say, hey, we're here for you, what do you need, and you can come back to us whenever you need, with maybe they need a story, maybe they are finally deciding they do want to do something on maternal mental health, and they're like, well, what do we do? And they can come back to us and say, okay, we need help writing this. We want to make sure that we're always saying, we're here for you, we want to be a resource, and not just constantly asking for something as well.
That's really interesting.
Can I add to something we said? Because what you said was very important in terms of getting creative in your messaging based on your specific audience, based on the legislator you're meeting. Maternal health is an issue that really cuts across most political interests, in my opinion. You can find a passion within each legislator and make a connection into the maternal health space, but you have to get creative sometimes. So patient stories obviously is very important, but we all know politics is very tricky, right? So just because you have a great story, just because there are patients advocating for something, doesn't mean something's gonna happen. So how can we cut across political interests? The economic issues is critical here. So if you're talking to a conservative lawmaker, coming prepared with how increasing access to some of these technologies to improve preterm birth rates, the incidence, C-section incidences, how that could save costs long-term for their Medicaid program, that's huge. Or think about all of the legislators that care about jobs and business and economic development. If I can guarantee your county that I can provide really good rural maternal health care, that makes it more likely for a family to stay, right? So you can really start to build creative coalitions by thinking about this from an economic development lens. What about bringing in the utility that represents that region? Utility companies make money based on the amount of people who buy their services. So if you can make this an economic development argument about people wanting to live in a community where they have good access to healthcare, you can start bringing in local chambers. You can start bringing in utilities. You can build a really robust coalition that actually speaks to that specific legislator's interests. So you can get kind of creative, but you got to know your audience before you meet with them.
So let me poke at that a little bit. I completely agree with you. One of the challenges I think in 2022, or something we're hearing space is that, and I think it's happening in Congress, but it's absolutely happening at the state level. There are states where advocates are being told you can't say the word equity, you cannot talk about racial justice or structural racism. There are bills out there all over the place to forbid training, public dollars being used for training around equity and things like this. When we're driving forward the maternal health agenda, it is impossible to do this work and probably not even ethical to do this work without being completely honest about all of this. How are you all threading the needle and making, like, keeping steady with this to what our values are, to what our core is, making decisions about what to say and what not to say, when we're in this really dicey time where we have lawmakers, I will not name the states, that are absolutely telling advocates and organizations and programs they fund, say it, write it, have it on your website, I'm not gonna play with you, which is insane, but it is happening, and it's happening in more places than we should even be allowing it to happen. For us to be able to stay steady to our commitment to equity and racial justice, what's your advice? How do you do it?
First, Lori, I feel like you know my life. Living in the South in a very conservative state, and then also working for the Center for Reproductive Rights, it can be really hard at times. But I also think that that's where partnerships are really critical. So I think that to be true to my work and to the work of the center, there are certain things that we have to say and that we will continue to say. But then we're also really strategic in working alongside organizations that may have the ear of the Speaker of the House in the state legislature, but then I might have the ear of the Legislative Black Caucus, and then we work from all angles to put pressure, right? And I think that that's particularly critical when it comes to our engagement with our key legislative committees. So you have key advocates working with key folks to make sure that this issue or this bill moves through whatever, it's, whether it's the Health and Human Services Committee or just whatever it is. And so I think that I think when it comes to policy, compromise is something that we have to talk about all the time, right? And I think that for some organizations, we draw a line of, well, I don't want to compromise on this one thing. And then for other organizations, they do make those compromises. I think that sometimes we just have to decide, is the end goal to just make some progress and then we keep revisiting, which is sometimes what has to happen. I mean, one example of that is, our fight to get postpartum Medicaid extended in Georgia. And our first approach, we wanted for 12 months. Georgia was one of the first to extend coverage, but they only extended it to 6 months. But it was an incremental step, right? For us to just
and
walk.
It was Georgia.
And it was right. Right. And I get some credit for that. It was really important. And for us, it was like, okay, 6 months is still better than 60 days. And we also made sure that our legislators were committed to revisiting it in the next session, which they eventually did, and got us to the year. But it was another example of where, one legislator we worked with, we had all kind of language about human rights and the right to health, and this is important for our, Black and low income and rural residents to get this extended coverage. And that bill just sat there. And then there was a bill that said, we're just going to extend coverage, and it was the shortest bill I've ever read. That bill passed, right? But the point is, through our advocacy, through our testimonies and things like that, we can weave that language in there when it's appropriate and when we can. We can use the media to raise those issues. But I think it's also us being really realistic and saying that, am I expecting the lead Republican to admit that this is a racial justice issue? Probably not, but we know it is. And we know that that extended coverage is going to address some of these core issues that we're working on. So partnerships are key.
I love that. Another Southern girl here will absolutely agree with that. The partnerships are key, knowing when we should lean in and lean back. Within, I'm physically located in North Carolina. Was just speaking earlier about space where we are leaning back in our state because we do want legislation moving forward. And you know what? We don't need to have our name on it. We don't need to be, but we know that this bill will support the BIPOC communities, and we know that this bill is going to help improve health disparities. We're going to continue to talk about that and weave that narrative in the press and raise the issues. But if we need to lean back so that other folks can stand up and put their name on it, we're okay with that. Whatever is for the better good of improving the disparities and get that bill passed is what we want to do.
I wish we had the map of looking at which states went first for postpartum Medicaid coverage, because it wasn't the places that are the normal places to go first. So I think that strategy, whatever it was, you've made the case over years to actually do that. So I think that's really important. The partnership piece is so critical, and I think it's going to be even more critical in the implementation phase for some of these things and how these partnerships stay together. I know that the American Heart Association about I think it was November 2020, put out a presidential advisory on structural racism. And we're seeing, it's a moderate organization, I'm saying that in air quotes, I should put my hands down, that's a good thing. And people like our partners sometimes pull that out. And they're like, well, the American Heart Association said this, which I find super flattering, working for the American Heart Association, and surprising. But there are partners, like every sort of moderate, big nonprofit is done those things. And I think thinking about how do you pull those out, how do you use those things? How do organizations like ours actually stand at the front of things when other organizations are taking the hits? That's what I'm excited about seeing happen, and I think how these partnerships stay engaged at the federal, state, and local levels is going to be the test of how well babies and moms are actually going to do long term.
Yeah, I appreciate those comments. I'll just share like an example of a real life scenario that we had this past year in Tennessee, where we were looking to pass legislation, and we created a whole new concept. We created something called remote patient monitoring for maternal health. Two legislators we were working with in the Senate and the House had personal experiences through their own maternal health journeys and wanted to make a difference in Tennessee. And in order to kind of inspire others to get on board, we cited like groups like March of Dimes that have great statistics. So I was talking to legislators. Did you know March of Dimes said that the rate of preterm births in Tennessee contribute $425 million in costs annually for Tennessee alone, right? I mean, that's an eye-popping number. Then we're still facing some challenges in trying to like demonstrate why this legislation would be important in Tennessee. So we had the state legislators ask their Medicaid agency, so state legislators making a request of their Medicaid agency in Tennessee to get us the number of preterm births, number of C-sections, because they keep track of these things through coding, right? So we can get a better sense of what those actual numbers look like in Tennessee. Then you can start getting creative by like looking at medical journal studies that talk about certain, if we implement this type of procedure, here are the reductions in preterm births or the reductions in postpartum hospital admissions that we should expect. And so you start tying these things together and you can create a very compelling story that legislators will resonate with, and you're creating a reason to support a bill without ever getting involved with some of the dicey political rhetoric, right? Unfortunately, we were not successful this year in getting the bill through Tennessee. We ran into some challenges with the fiscal note, which is a whole other challenge. The fiscal note only looks at the cost for implementing this type of technology, doesn't consider the economic benefits long-term once you implement this types of technology. So we have some work to do in working with the administration and the fiscal note group to try and make improvements for next year, but we're gonna make a run at this next year. March for Moms was awesome in lending their support to this effort in Tennessee, and hopefully it's a start of a conversation where we can move these types of policies forward.
I mean, one of the things to keep in mind is how often do we hear that line, among industrialized countries or developed countries, U.S. ranks last, right? If you break that data down, and I do because I'm geeky, the results of this, the U.S. has a maternal mortality rate of about 23. The next highest large industrialized country is South Korea, and they're at about 11. So if you say, well, yeah, but we have these disparities, and the disparities are real, structural racism is real, but what if we just looked at white mothers and the outcomes for white mothers? Then instead of the United States being last, we'd be last at 17 per 100,000. And so one of the ways we make this argument is our health system has all the problems with racism that we've talked about, but in making the argument, it's not serving white mothers particularly well either. And it goes beyond it. I mean, we have to make that argument. There's systemic problems in our system that go beyond the real factors associated with race. And I think the kinds of things people are talking about here are the ways to frame that going forward. I mean, it's great themes here in terms of compromise, giving up credit to get success. Those are core elements in advocacy programs.
And another thing that I think about is I had a mentor say to me once that, we need all the players on the chessboard. We need the folks who are saying, okay, we're just going to burn it down. And we need the folks who are taking a more pragmatic approach. And that makes me think about, how important all these partnerships are and being able to call on different partners when you need them. But, if you have the organization that is the burn it all down approach, we need you. And then we also need the more moderate organizations because there's a time and a place for all these different players. It's important for us to all have our roles.
So we've heard from that, like, we all talk about silos, and not to say you're all silos sitting up here, but there's so many different issues that cut across maternal health. What tables are you at, Lee, right now, or any of you, where those conversations are happening between the burn it down groups and the compromise? Like, how are we all organizing together to make it easier to get what we want from the folks, the decision makers? What are the different structures that you all are part of? And is the table big enough? Are the tables broad enough? Do we need to be more inclusive? Are we getting community voice? And give us, what should we be doing here to make this better? Because I agree with what you're saying, but are we talking to each other? Like, do we know what the burn it down people are saying?
I was part of a National Partnership for Women and Families. They host a table called the Women's Defense Table, which actually is how I met some of the people in this room. It is a very big table. If you're an advocate for women's health, you will likely be able to join it. And so that was a great opportunity to learn from other folks what is happening, and also to say, okay, can we help support this? Maybe we can't support it, but we're not gonna not support it, vocally, and just being able to have a place where you can talk about different topics, you can learn from each other, you can share sign-on letters and opportunities to get engaged, to amplify on social media, and knowing what is your role to play, where you should step up and you should be the lead, where you should be the supporting organization. And I think, like you said, making sure that the table is wide enough, I think, is really important.
Brian, did you find a table in New York?
I'm building one. I think is really kind of more to the point. There's a couple of medium-sized organizations that are really locally taking the bull by the horns in this particular case. The government, 2017, the state government started a maternal review board. They spent about 2 years on that, released a report. Some of the findings have been implemented over the last couple of years. But I definitely see people and I hear them, and I know that I understand where they're coming from. Healthcare is broken in this country, right? This isn't a maternal health issue. Healthcare is fundamentally broken in America, and I don't think there's anybody in this room who could say with a straight face they don't think a woman deserves a year off after having a baby. And if I'm wrong, please feel free to correct me in this group of soon to be very hostile people. So, right? I don't think there's anybody here that that doesn't believe that insurance should cover a woman's postpartum health bills for a year. I don't think that I don't know reasonable people who don't believe those things. But also I don't know that there's a whole lot of people here who would disagree with the idea that healthcare should be affordable. It should be accessible to everybody, right? These are fundamental things that we should all reasonable people should agree on, and we have a fundamental disconnect with how we implement that in a country where we have unbelievable resources in a world where everybody else is figuring this out, right? We have, at the risk of going on too long, I apologize, but we have a collective generational trauma in this country around work, around toughness, or we have the bootstrapping. We don't make stuff easy on ourselves on purpose, right? and we can, you know, we can be philosophical on the reasons for that, right? But like, I want to change. You know, I want to change the world. I want to change our healthcare system. And I appreciate the people who recognize that the system is broken and want to burn it all down and try to build it back up again. I appreciate those people very much. I recognize that the climate right now is not sufficient to take that approach, in my opinion. Others may disagree with me. But I'm not saying that we won't get there. Maybe we get there in 5 years. Maybe we're there in 10 years. Maybe something happens tomorrow that is just so absolutely horrific that we have to change, right? What does that look like? I don't even know. I don't even want to think about it because we just had 20 kids die in a school in Texas and we can't ban guns, right? Like, what does it take? What does it take to change it? And that's a question that I ask every single lawmaker I talk to. What is it going to take to change your mind about this? And they don't have answers for that. They don't know what it looks like. You know, they're mostly practical people. They're mostly people who talk to their aides, talk to the finance people. They talk to the people that are spending the money or who want to spend the money. They know what they have. They know what's in front of them. State governments can't run deficits, right? Like, they have limited resources to spend. They know they can't do it. I mean, we got a Democratic supermajority in the New York State legislature, and we've had it for 2 years now. Do we have the New York Health Care Act passed? No. Why? Because it's expensive. It costs a lot of money. Insurance companies want to stay afloat. Right? Lobbyists are against it. Right? Like, all these things play a part in this. You know, yeah, burning it down looks really appealing. Right? I get it. But like, in the meantime, you know, I really hope that the people who want to burn the system down look at those of us who are just trying to do the little bit that we can do, a little bit at a time, a little bit at a time. Take a bite here, take a bite there. Like, that's what you do when you're recovering from trauma, right? Like, you grab a manageable bite of something and you take care of it. And then you grab another one, and you grab another one. And eventually, we'll get to that place. And hopefully we get to that place where something bad enough happens that requires burning it down.
So we've talked about industry, we've talked about nonprofits and organizations and coalitions. Let's come back to grassroots again, because I do wonder, and I'd love to hear from all of you some examples where you've seen grassroots advocates like working with a person who represents them in whatever elected body is make a difference. And I'm going to start with your team because I think you guys do this so well. Like, what does it take to get to critical mass? How many parents? How many advocates? How do you move from high tech to high touch? And I have a second follow-up for you because you've done this during COVID and had to figure out how to change your model. I'd love to know what worked so well during COVID in your grassroots model. You want to keep it going post-COVID.
Yeah, I'm actually gonna share a story where, you know, when the world shut down on March 2020, maybe the third week in March, we started hearing from parents who were expecting and were really scared. I wasn't sure what we were going to do with all this information, but I said, parents are scared. I wasn't sure what the policy solution was going to be. But I know that something is going on, and we need to be able to support these parents. So we just put out sort of a call. What are you, new parent or a pregnant person that's expecting, what are you experiencing right now? So what that ended up being was that we started finding out, like, there started being a trend in our stories. There started being, I'm scared I'm gonna have to deliver alone. My partner is not going to be able to be with me. A doula is not going to be able to be with me. I'm scared my baby's going to be taken away. I'm scared I'm going to die. And so, as you come at, right, March of 2020, we can rewind back there. We had no clue of anything. So we just started collecting those stories, which then fed into some of the policy changes that happened. The CDC was at that point in time recommending separation. At that point in time, it was recommending separation because we didn't know, right? We know so much more. We didn't know. So we were able to take our member stories and share them with the CDC and say, we understand that this policy was not what you intended, but this is how it looks in hospitals. This is what families are experiencing right now. And so we were kind of able to make those shifts, and so able to immediately jump into action, just take what we were hearing from our members, take those feedbacks from emails we were getting and from social media posts we were getting, and then we sent one back out and said, hey, share your story here. And we were able to take that and put together storybooks that we would send to agencies. We were able to send it to lawmakers, and we were able to push it out to the press again, just to raise the voices of what real parents were going through. And during a time in which nobody knew where we were going to be and what was going to happen, and death, the fear of death was real. And as we continue to get those stats, so grateful that we were able to do that. And that's just one of many stories.
Are there ways any of you, and including obviously Moms Rising, were able to connect with lawmakers differently during COVID, or connect the grassroots differently during the pandemic that worked so well that you want to replicate it?
Initially, I'd be curious, initially lawmakers were excited to get on Zoom. We could get a lawmaker on Zoom really quickly because they wanted to, right? They wanted to be accessible and they wanted to know what was going on in their districts. They were also isolated. So those continue. They look a little different now. But I think one of the ways that it has continued is it does allow, I'm in North Carolina. It allows me to be able to connect with our members who are in Washington State and get them with, the members or the members themselves or the lawmakers. It is a great equalizer. We have parents who have, parents who've testified before the House Ways and Means Committee, who would not otherwise be able to travel in Washington, D.C., definitely not during a pandemic, definitely not with young kids, who were able to be on Zoom, share their real-time experience, have their kids coming in and out of camera, share their real experience. And so grateful that, if we look for silver linings of the pandemic, grateful that the pandemic has shown us that these tools that we have can be really, really good in moments like this.
Well, just to build off that, yeah, I definitely think that it has expanded accessibility to lawmakers and to the Capitol, because right now, even for committee hearings at the state level, they're still allowing folks to Zoom in, which has been nice. And then it's also been a challenge in a variety of ways, but this past session in Georgia, I distinctly remember a lawmaker requesting that we get a lot of moms and babies down to the Capitol. And we thought about it, but then we were like, we're still in a pandemic, and is it really responsible to have large numbers of vulnerable people in the Capitol when many of the mask restrictions are no longer in place? And so I think that we've had to make a lot of decisions about the pictures that you used to love with all of the advocates standing on the state Capitol steps and things like that we just no longer do, but try to think of other ways to have that type of impact with the lawmakers has been a challenge, but I think we figured out how to navigate it.
Other ideas about how folks have been able to stay connected during the pandemic? Any desires to continue using technology? I know in some more rural parts of the country, having access to lawmakers, and if you're not going to go to the state capitol or to whatever it is, that's huge. And I don't know if we're going to all fight to keep that there, because you listen to what the decision makers say they want more than what we kind of need. But I'm curious if that's gonna hold on. I have a data question, so I'm going to look, Jean, at the end of the table there to you, that I think all of you probably thought about it or done it, and I'd love some examples for folks of how you've been able to customize or tailor data to the legislative district level, if you have been able to, and how that's different than state, federal level. I mean, we're always looking to do it, but I'd love some ideas from others if they've been successful doing that.
I mean, it's possible in some cases. The difficulty with maternal mortality in particular is it's too high, but it's sufficiently rare that we have 3 years of national data now, official national data on maternal mortality, and we still have, I think, 9 states that don't have 10 deaths that you could actually, and we won't report it. So that's out. And there's a measure called severe maternal morbidity, which is more common, but a little bit more esoteric for people to explain. But I think you can look at a whole array of other health outcomes, from infant mortality, which is regrettably more common, to fetal death, to things like cesarean rates and prematurity rates. The challenge is just getting people to think in those terms, right? Talk about silos. Researchers don't necessarily think in legislative district terms and have it organized, but more and more people are getting better at it. And we're so far behind. People with a lot of resources have been doing this for years. And we're just at the point where we're starting to think in those terms and organizing data in a way that allows you to do that. But I think it's also an important balance to maintain. We lose somewhat on the data side, but we win on the story side. And so it's always that intersection between this story is a horrific story that I've experienced or someone has experienced, but it's not just this, it's also, and that's where the data is critical, to allow that to be generalized to the larger population.
I have one last question for everybody to answer, and then we're going to open it up for other questions, and we have microphones for folks when we answer them. And this is like the optimism question. So I think it's probably fair to say that all of us watching, I know you have hope, so maybe you can go first. Maybe you can go last, so we can do that. Just watching what's happening in Washington right now, we don't know what's going to happen, period, like full stop. How can we collectively, everybody watching this, stay focused on what is most important? Like, what is your advice to that parent sitting out there, that advocate, that staffer for a member of Congress who's been trying so hard and is just feeling beleaguered right now, like this doesn't matter, it's not worth it, it's never going to matter, nobody's listening. What would you say to them to sort of break through this place to get us to the better place? Brianna, I'm going to just, if you don't mind, because you're lit up.
Yeah, I think you're right. I mean, it's all about hope, right? I think we have some really good examples of where we've been surprised that things actually move. So thinking back to the state level about postpartum Medicaid being extended to 12 months in states that have not even expanded Medicaid more broadly, right? So leveraging those glimmers of hope and thinking about how we can scale it up, how we can expand it to other things has, I think, been really kind of that source of hope. I think the other piece, though, is to keep dreaming. I think the Momnibus is a great example of a package of bills that, number one, was designed to be a gap filler, right? The Momnibus isn't the end-all and be-all, but it's a gap filler. It's a demonstration that it's going to take more than one policy to address this issue, right? And so I think that from that, advocates can take, we don't have to have just one thing that we're trying to accomplish. We can throw all of the things out there and see what the lawmakers pick up, right? And then we'll run with that. And then we will remind them, but hey, we also need this thing over here. We need environmental justice. We need access to doulas. We need access to midwives. So I would say, cast that wide, that net. We'll see what we catch, but also constantly be ready with all of the other things we want, because to your point, Lori, we never know when a legislator might mention they love midwives and want to figure out what they can do about it. Well, guess what? We have some ideas on that, and so just stay ready. Be willing to jump in, with whatever the opportunity holds.
Yeah, I'm very hopeful. I see some tremendous leaders in state capitals who are embracing this issue. I'm also seeing different organizations that focus on robust policymaking across all 50 states focus on this issue. I'll give you a few examples. Anyone here from New Jersey? New Jersey.
And she did it proudly.
Yeah. First Lady of the Governor, Tammy Murphy, is arguably the most important maternal health champion in a decade. What she's doing in New Jersey, which had one of the worst maternal health outcomes when the governor took over, is tremendous. I would encourage everyone here, write down Nurture New Jersey, Nurture NJ. That's her robust program. It's looking at maternal health completely holistically, bringing all these stakeholders together. They're rolling out these innovative solutions that they're actually implementing in their communities. It feels like every single month. What's really cool about this is that next year, her husband, Governor Phil Murphy, is the chair of the National Governors Association. And they're making maternal health best practices a platform for next year's policy work across all 50 governors. So for an entire year, they're going to be running workshops, listening to what New Jersey's done, and try and create best practice models across all 50 states. The other thing I would say is the National Conference of State Legislatures, which brings together state legislators across all 50 states. They have a maternal health cohort that they run every single year. This in that space, the speakers or the Senate presidents in these state chambers will nominate someone who they want to become like appointed as like the maternal health thought leader in their legislature, and they're joining these cohorts, getting trained by providers, patients, you name it, community leaders on how to implement some best practices. So I'm a little bit optimistic, especially at the state level, to see some change hopefully in some of these harder to reach states. They're sending people to these cohorts as well. So hopefully we'll start to see like wheels turning, things moving. It'd be great to see what New Jersey's doing, implemented widely. But yeah, I feel optimistic.
Are you optimistic, Gene?
Yeah, I mean, the advantage of being, as we would say in Boston, wicked old, is that you've seen cycles over time, right? And how things have changed. And before you can get on the policy side, you have to be on the agenda. And historically, we've not even been on the agenda. Right? People don't even discuss issues of maternal health. They're discussing issues of maternal health now. They haven't done everything we wanted or even much of what we wanted. But at least we're at the table now in a way we haven't. We wouldn't have had a thing like this 10 years ago. We wouldn't be discussing it 10 years ago. And I think part of the challenge for us is going to be to move from discussions of maternal mortality to maternal health in general, and women's health in general. And if we can use the crisis of maternal mortality as the venue to get them talking about women's health in general, okay, right? You take your victories where you can get them. The other thing is even the things that haven't gone through, Momnibus being an obvious example, have solutions. And part of the policy process is giving them solutions, right? Is there a simple solution to this problem? There really is. But if we can suggest, take these steps, you had asked us before, what would we suggest? I'd say midwives. Train and expand and diversify the midwifery workforce. That would be the simplest, not simple, but simpler than expanding. And one last statistic. Unless I meet you on the street, and then I'll tell you a whole bunch more. I just do that to people. If you compare the United States to other European countries, or comparable countries, we have a comparable number of OBs to those countries, OBs per 1,000 births. We have 1/9 the proportion of midwives per 1,000 births that all those countries with better outcomes have. And so if you want a good solution, that's the solution I would argue for. That because we can train people more quickly, we can have them based in communities, we can make the difference in a way that would actually work.
Yeah, so first of all, I'm gonna say that as an advocate, this work is very tiring, so if you need to take time to grieve, if you need to take time to rest, take that time. And then come back to work, because this work is never done. Like some folks have said up here, you have to be ready for when that window of opportunity strikes, especially at the federal level. So continuing to push and waiting for that window of opportunity, but also just really, I think, taking inspiration and finding hope in all the incredible things that are happening really at a community level, right? Like our policymakers aren't always showing up for us, but as a community, we can show up for each other and we can help to create the support networks and the mutual aid that we need to keep going in the meantime. So I think really getting your hope and your inspiration from the community level and that grassroots level and continuing to push at the top. And remembering that we all have power, and to recognize that and to use your power where you are today to do what you can.
Yeah, she stole my answer. Yeah, so I've been doing this for 4 years. I'm exhausted. Not gonna lie, right? Like, I ended up hospitalized for 3 days at one point just from electrolytes plummeting from overwork and stress and whatnot. Take a break when you need it. The other thing is she also answered. Show up for each other, right? I've been an organizer for the last 6 to 8 years in various capacities. You cannot overstate the value of people showing up for something. I think probably everybody here who's tried to organize something has been sitting in like a lonely venue space with like 10% of the turnout that they were hoping for, right? Like we've all been there. It sucks. Numbers matter. Numbers count. Like it generates interest. It generates influence. I mean, and it's never been easier, right? Like share social media posts, right? Comment on it, like and subscribe, whatever, right? Like those things matter in this day and age, and they're easy. So I guess if I had to say one call to action for everybody out there who's tired and beleaguered and doesn't think it matters anymore, go ahead and take a break from your work and show up for somebody else's.
I am happy to take anybody and run away if necessary. I often run away to the beach whenever I need to, so come join me. But you know, the things that give me hope, I've been doing this for a few decades, just down the street. I started at that big white building at the other end of Pennsylvania Avenue, and the room looks different now, and that's exciting. The room is different. The people who are coming in and out are different. The people who have access, the people who are the people we're trying to have access to are different. That's inspiring. A local policy that I worked to pass. I happened to be sitting in the local town meeting space, and a police officer came up and was just sharing it was paid family medical leave, and he was just sharing how he had just gotten back to duty because he took paid leave, something he never thought he needed, something he, was just a gift to him and his wife, and how he's still married after all these years because he was able to take paid family medical leave. And then he started talking to me. He didn't know who I was, that I had been a part of this effort. Started talking to me about we need breastfeeding protections, and I was like, tell me more. But he didn't see himself as an advocate. Here he was, just someone who benefited from this policy that I was grateful to be a part of, being able to help advocate. But he didn't know. He was just sharing what was good for him. And I just talked to him about that importance of sharing that story. Come to find out, he was the first police officer that was able to take this leave, and then he did. He continued on to talk about why breastfeeding was important, why we needed to have a more holistic approach to how we support families. Didn't see himself as an advocate because he's just a regular person who we need more voices talking to decision makers. And so it's just small. I have so many of those, which is small conversations like that always leave me hopeful, because we've moved huge swaths of people, but we've also moved individuals to see the importance of these policies. And I'm so grateful to be able to do this work, and grateful to be able to do this work with all of you and with everyone who's listening and everyone in this room, because it's important, and we may not see all the fruits of all of our hard work, but it is happening piece by piece.
I love that. I think amend what you said about people seeing themselves as advocates, and how we can all also be looking at every advocate to see themselves as a decision maker and starting to run for office. There's so many people that care about these issues in the United States that to start talking every time we are, just ask them, "Did you think about running? You thought about running?" You just never know, because that's how we're seeing. You're right. I mean, you gave me the chills when you talked about walking into the it is different, and it's different around the country, and that's not a small thing. But we need to have more people seeing themselves at those tables, not just at these tables. Although you've been an awesome table, a really awesome table. We have a few minutes left here, and we'd love to ask if folks have questions, or if there are other great ideas from your organization or your experience you want to share. And we have somebody. Oh, there are two people. So start next.
Hi everyone, thank you so much. This panel has just been so incredibly insightful, and really appreciate all of you. My name is Samantha Banerjee. I'm the Executive Director of Push for Empowered Pregnancy. We are a new organization. We just launched about a year ago. We are probably one of those burning down organizations that we were talking about, and we are dedicated to stillbirth prevention. And we are, first of all, so incredibly grateful because there are so many people in this room individually whose organizations have played a huge role in all the progress that we've made in the past year. And so first of all, thank you, and what you're saying about showing up. I'm a perfect example of how showing up for other organizations really does matter. I mean, everyone I speak to is like, I can't believe you did all this, and it's only been a year. And I keep saying I can't take credit for any of it, because we've just had so much support thrown behind us from so many places. So thank you all, first of all, so much. But my question for you is, so for the last probably 6-7 years, those of us in the stillbirth community have watched in awe as all of you in the maternal health community have gone from, like you said, 10 years ago, nobody talked about this. Now, this issue of maternal mortality, Black maternal health in general, is in the national spotlight. This is something that people talk about, that the average person is starting to become aware that this is happening. And you know, we faced the same issue in stillbirth, and that was why we launched our org, was to try to emulate what you have done. So my question is, how did you do it? How did you go from nobody wants to talk about maternal health? I know you spoke about how just the change in the wording from pregnancy to maternal made a difference, and you know, like what were those things? What were those catalysts that really drove the change to make this something that people empowered cared about?
The first thing that I think of is the ProPublica Lost Mothers series that they did. You know, and that was a journalist who was really lifting up personal stories of folks who had been affected by maternal mortality, getting the statistics, and it really got it out in the public eye. That was picked up by, you know, other media companies where people started to talk about it. And then it seemed to be the hot policy issue after that. So I think often it just, and that comes back to what everybody's talking about, the power of storytelling, and how are you getting those stories out there and then using that momentum.
Yeah, so I would be remiss if I did not mention the Black Mamas Matter Alliance. I sit on the board. I think that there was a concerted effort to shift the narrative around maternal health, maternal mortality, maternal morbidity. And I think that absolutely the media strategy was one part of that, the storytelling, a major piece of it. And I think that making sure that you are getting that story out there, the impact of it. I think the other piece of it is that we have to not silo the issue, right? And so I think that we're experiencing that now, where we're taking the conversation beyond just maternal death, and to Jean's point, thinking about maternal wellness. And so we're including conversations, like we've been talking with the National Birth Equity Collaborative about how do we talk about access to fertility care? How do we talk about these other things, right? And so maybe the point is not for you all to like just suddenly break out all new with the stillbirth prevention, but how do we make it part of the conversation that if we truly want to support maternal wellness, then that means we're looking at the full spectrum of care and making sure that folks have access to what they need in order to prevent stillbirth, that they have access to be able to get fertility treatments and things like that, and making it part of one conversation instead of trying to launch a lot of new ideas, because I think it's hard. I think it's really hard, and I have to give a lot of credit to Black women in amplifying this issue to the platform that it is now, and that includes a lot of Black women lawmakers. I mean, I think, Jean, you also mentioned the Black Maternal Health Caucus, the work that Congresswoman Alma Adams and Underwood did, VP Harris. I mean, these were the voices at the forefront that really pushed it beyond. I know we had the Preventing Maternal Deaths Act back in 2018, which was really data quality driven, which was important. But when we talk about maternal mortality from a comprehensive perspective, it was the Black Maternal Health Caucus that has really pushed that forward. And so I think maybe just thinking about, who are your champions, who will be able to keep that conversation at the forefront will be really key, but also leverage the conversation that's already happening and figure out how can you fit in, who can you partner with to take it to the next level.
Good morning. Can you hear me?
You're right here, so we can hear you.
Okay. Good morning. My name is Jay Wilson. I'm the founding president and CEO of Melanated Moms. All of you are speaking directly to me. I don't know if you guys knew that, but every one of you have different parts of your work and your story that really enhances the work that my organization does. And I'm just very grateful and thankful to be here and to be able to listen to you guys. Now, my questions, a little complicated, but not really. You, Mr. Jean, you spoke directly to me in terms of data and statistics. I love it. I wish I could be a statistician. Like, it's just like a thing on the inside. But my question is, how do we create better language around health equity from a long-term standpoint, when it comes to maternal health? So, little background. So, I'm a mom. I'm a 4-time survivor of preeclampsia. I lost 2 children prior to giving birth to my first live child, and my last baby was born 10 years ago, and I still have residual issues, cardiac and all these other things from my pregnancy. So, we talked a lot about extending maternal health, postpartum care by 1 year, but I don't see a lot of information or language around long-term health issues that can happen that stem from, high-risk pregnancy. So how can we change the language so that it becomes a health issue and not just a maternal health issue? Or, you understand what I'm
Yeah, oh
saying?
yeah.
Thank you.
Since you pointed at me, I guess I have to answer. There's a couple things to keep in mind. It sounds really geeky, but there's people in government who are actually working on some of these things, right? And NIH has public meetings where they actually ask people to contribute to that. And I know that sounds esoteric, but they fund the research. They fund the big, complicated research that can drive these things. It ties into your question a bit too, because at the same time ProPublica was doing that, CDC was mounting an effort to expand the number of states that had maternal mortality review committees. And that was an entirely separate process. But if you can find advocates within the government who are doing this, that can be really critical, because to answer your question, you really need people who have longitudinal data sets, right, who can follow people for a long time. We have one we developed in Massachusetts years ago, but I'd say there's probably only half a dozen states that have anything like that. But the only way you can look at long-term effects is to make sure you can follow people for a while and see how they fare. And if you can do that, that's possible, but the only way you can do that is to have enough money to do it. And our initial funding came from CDC, and then the Mass Department of Public Health kept it going. But NIH has more money than anybody. And if they fund that kind of research, it'll happen, because people are seeking that kind of funding. One other quick side note for you, FEMA was a hot issue in the past. Fetal infant mortality reviews was something that was really popular maybe 15 years ago. I mean, they're still around, but I think they've lost some of their sheen. And one of the efforts that you might be engaged in is to expand that effort again, to reinvigorate that effort, to start asking those questions. And again, that's a CDC-funded project. So there are people within the government who want to do these things. Sometimes they need a push from people on the outside to be able to get their own bosses to allow them to engage in that.
Make a commercial. The American Heart Association also has 2 initiatives that might be useful, and we can connect on it, but the hypertension initiative and the maternal health initiative, looking at longer term implications. Things you were saying are in a couple different papers that just came out, so I'm happy to connect you.
Thank you.
Other questions or ideas?
Yeah. I just want to say thank you so much for all of your insight today. So I'm a women's mental health psychiatrist, so I only see women, so all the fruits of your hard work I get to see every day, which is amazing. My question for you today is, how do we have a call for action for physicians to get more involved? I think we are a very, I think there's a lot of potential there to get involved, and as I see a lot of women physicians, especially now that more women than men in most med schools, so we have a lot of women physicians who actually come out of the workforce to take care of their families or for health reasons. There's a lot of potential for these women also to get involved, and they're looking to get involved in something that they're really passionate about, but sort of feel hopeless or defeated, and so that's my question. Thank you.
I would love to start with that, because I might send that back to you. in the sense that I'm so grateful for the healthcare providers who I have been engaged with, and I'm always saying, how can I continue to engage with your counterparts? Because there's so many different avenues that with the support of healthcare providers could be really, really, really critical. And so just some of the things that some of the providers I've worked with have done, help write LTEs or op-eds, help testify before Congress or state legislators help to, sometimes they're in leadership positions in their various professional organizations, so helping to ensure that those work groups contain folks who are most impacted, and insisting on that is something actually I've been really, really strongly pushing on. But that I appreciate you're asking that question, because that is a question that I am continually putting out. And I can't tell you, in every space that I'm in, when I have a physician or a group of physicians that come in and who are standing up and who are speaking, it's so powerful. So I'd be curious what my co-panelists have to say, but would love to talk with you more about that and work to make that happen, because there's a critical voice, and I'm sure we would all be happy to help make that happen.
Thank you.
I would say I echo everything. I mean, it's amazing to me how lawmakers respond to physicians, and so I think physicians are incredibly impactful and effective advocates. I also would ask physicians to share power, and I think, Tina, a lot of what you were saying was about that. Be allies and accomplices on policies that may not directly benefit physicians. So a lot of the conversations we have around implicit bias trainings, there's pushback, doulas and access, and just the thought of more doulas at the hospital sometimes scares physicians. The efforts that we're doing to expand access to midwifery care seems to be like a direct threat to physicians at some times. And so I ask that physicians think about how to really become like a partner in some of those policy-driven discussions that may not necessarily center on the healthcare system itself or directly benefit the physician or the provision of care in a hospital system, but how can the physician really lend support and lend their voice to supporting that community-based approach to maternal health care. And so I think, Tina, to your point, part of that is, how can we have those conversations with the physician community of how to better leverage your influence in those discussions, I think would be really helpful.
I really appreciate that insight. I have to say, I totally agree with you, like 150%. And I think it comes down to just education, right? I mean, even for us physicians, I mean, like the number of patients I see who are like taking off their medications, and it's like, go like be pregnant and be happy or whatever, or told like you can't go to a midwife, right? I mean, it's like education on all fronts, and so the points you make are so powerful, yet I understand them, and I can't unfortunately say that that's all generalized to all physicians. This is the work I do. I'm around women, I talk to women, I listen to women, but it just comes down to education in my opinion, but thank you very much.
I think you could also be a good evangelist within your profession. Like everybody who goes to medical school or gets a degree in public health should have to take an advocacy course. Maybe policy, but nobody's getting trained in advocacy until too late. So we need you on the inside just as much as at the state capitol. And we've got one more question over here, and then we're gonna probably have to wrap it up because I think we're at the noon hour.
My name's Michelle. I'm a local DC, Maryland midwife, nurse midwife, hospital based. I also work with some of the people here on DC legislation. And one of my comments, and a few of you have touched on, diversifying access to birth workers, increasing access to midwifery care. I have been astounded this year, as some of us have worked on the CM bill here in DC, on how people don't even understand what a midwife is and what that means in care. So I think that's something we have been trying to work on, and we need to expand that. I also think there's a growing fear that we should be educating clients and patients on empowering them to take charge of their own care as well and do really good shared decision making, which I think historically in the medical model in the US that has been, it hasn't been encouraged, it's a threat. So I always tell people, I want you to know just as much as me on that day that you go into labor, we're doing this together. It's shared decision making, it's really good consent, and always what are the risks, alternatives, and benefits. And another thing is I'm a third-year PhD student and learning about research and data, which is scary the longer I'm in this program because it's really crazy how we can manipulate data for our agenda. So I think being really careful on the words that we use and realizing that we talked a lot about personal stories, we're missing the concept of soul and the whole care of the person.
I think we are at the thank you point here, and I'm gonna go down and got Jean and Evan, Brianna, Lee, Brian, and Tina. Thank you guys. We're awesome. Thank you, Leticia. Thank you. March for Moms over here. You should come up and be seen on screen. You guys did such a great job. Thank you so much for putting on this event. Thank you for all of you being in the room, and anybody who's here remotely, please check out the March for Moms website. Stay mad, stay motivated, stay moving, stay together. Thank you all. Have a great Monday and a great week. Thank you.
We do have this room for another half hour, so if people want to stay behind and network and still enjoy some food and coffee, feel free to do that. Let's go.
Let's go. How you doing? I was going to let you get the picture first, but I was going to catch up. And I missed your introduction, your connection to this panel, so I have to find out.
Oh, great. It's wonderful.
Yeah, I've been here since Friday.
Oh, that's so nice. That is so wonderful. Well, welcome. I hope you see you. Yeah, just so you great. This is wonderful. I know. Tell me my friends.
Yeah, my grandmother was